Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. ATM Mostafizur Rahman, Assistant Professor, Department of Surgery, Bashundhara Ad-din Medical College Hospital. My student, today I present important topics like bile duct injury or post-operative bile leakage. We face the condition usually during operations or immediately after post-operative period. This bile duct injury is a disastrous condition which may ruin the patient physically, mentally and financially. Although the incidence of bile duct injury is decreasing nowadays because of development of expertise and particular subject and experience of surgeons, still it happens in beginner and careless surgeons. Therefore, it is necessary to know what precautions and safety measures should be taken during operation to prevent such iatrogenic incidents. And once the accident is happened, how to manage them successfully. It is more common in laparoscopic cholecystectomy injury operations as well as open procedure like open cholecystectomy. The causes of bile duct injury during cholecystectomy: ligation or transection of the wrong ducts. During operations, when we face the difficult situations of the Calot's triangle, you know the boundary of Calot's triangle. In Calot's triangle, it is bounded by superiorly the undersurface of the liver, inferiorly the cystic duct and medially the common hepatic duct. In these triangles, there is content of cystic artery and vein and a lymph nodes which is known as lymph nodes of Land. Sometimes we identify the cystic vessels separately and lymph nodes as well as all the three structures. When patient presents in chronic cases, there is a fibrosis of these structures. In these cases, the dissection of the Calot's triangle is so much difficult and the injury is more prone in these situations. The causes of bile duct injury is first ligation or transection of the wrong duct. The second cause is flush ligation of the cystic duct occluding the lumen of the common bile duct. Third cause is excessive dissection compromise the blood supply of the bile duct. So, the subsequent due to lack of blood supply to the common bile duct, the fibrosis or stricture of the bile duct is formed. The fourth most common is trauma of the lumen of the common bile duct during exploration by manipulation or forceful dilatations. And fifth most common cause is injury due to inappropriate application of energy source. We use the electrocautery or diathermy machines during open or laparoscopic procedure of cholecystectomy. Other causes of bile duct injury is present. The causes of bile leak after cholecystectomy is important viva questions or written questions in undergraduate or postgraduate examination. The causes of bile leak after cholecystectomy is oozing from the liver bed when we dissect the gallbladder from liver bed. Another cause is slipping of ligature or clips. During laparoscopic procedure, we use the clips, and sometimes we use the intercorporeal sutures. In case of open cholecystectomy, we always use the suture materials to ligate or transfix the cystic vessels and cystic duct. Then we separate the gallbladder by doing cholecystectomy and separate the gallbladder from liver beds. Injury to common hepatic duct, right hepatic duct, common bile duct, or sometimes accessory duct present in the body or fundus of the gallbladder. Sometimes it leaks the bile and bile collect the subhepatic space or any other dependent parts of the body. This injury may be complete transection or lateral transection of the bile ducts. Now we present the presentation of biliary leakage. The presentation depends on the presence or absence of abdominal drain. If the drain is absent, the patient may present with abdominal pain, abdominal distension, fever, jaundice, and features of peritonitis like abdominal rigidity, rebound tenderness, and sometimes patients develop paralytic ileus due to frequent irritations of the abdominal structures. And sometimes patients may present with shock due to lack of blood volume and due to continuous leakage of bile in peritoneal cavity, and sometimes patient may develop septicemia, bacteremia, and causes septic shock. If the drain is present when we use the drain during operations, in these cases patients may present with increased drain output day by day. Usually during first post-operative day, the drain is reduced and gradually the drain is increases day by day. Drainage material is bile strained It is an important sign of biliary leakage. Patient may present with pain, jaundice, and in these cases abdominal distension is very much rare and patient's abdomen is soft. Now I tell how I diagnose the post-operative biliary leakage. Usually I confirm the diagnosis by history, physical examination and investigations. In case of history, usually patients say the patients usually presents history of any abdominal surgery like cholecystectomy, either open or laparoscopic, or any upper abdominal surgery, usually GI surgery or pancreatic surgery. In these cases, the injury of the common bile duct or common hepatic duct is more common. Sometimes abdominal trauma, either blunt trauma or penetrating trauma, may causes biliary leakage. Then I examine the patients. In case of biliary peritonitis, there is a abdominal distension and sharp pain in the abdomen, and gradually patients develop nutritional imbalance and electrolyte imbalance. Now, how we investigate these patients and confirm the diagnosis of biliary leakage. If the drain is absent, when we not put a drain during operations, in such a cases we confirm the collection of the abdomen by doing an ultrasound or ultrasonogram of the whole abdomen to detect any collection in the abdomen. Then we do the liver function test like serum bilirubin. It may be direct or indirect or total, and HGPT and alkaline phosphatase. Usually in case of biliary leakage, serum bilirubin is more, HGPT is usually normal, and sometimes alkaline phosphatase is increases. Now I confirm or I investigate by HIDA scan, HIDA scan of bile duct to detect the site of bile leakage. Another investigations we will do, this investigation is more sophisticated and costly. This is MRCP, magnetic resonance cholangiopancreatography. This is not like, but this is like as an MRI of hepatobiliary system and pancreas. Then we do the basic investigations like total count, differential count, ESR and hemoglobin percentage to detect any evidence of infections. Sometimes we culture the blood and drainage content and detect the types of bacteria and types of suitable antibiotics to control the infections, and we will do the serum electrolytes, serum albumin, serum total protein, and sometimes we will do the investigations of renal functions like blood urea and serum creatinines. Then I manage the patients, or I treat the patients according to confirmation of the diagnosis and site of injuries. The immediate measures should be taken, and the treatment protocol is initial management and subsequent management. The initial management includes peritoneal collection of the bile is trained by ultrasound guidance, percutaneous drainage, and the drain tube is kept in situ for further drainage. Correction of dehydration and electrolyte abnormalities if there is any present. Correction of anemia if there is present, we will do the blood transfusions. Treatment with appropriate antibiotic and according to the culture sensitivity. Improvement of the diet. Patients usually transfuse albumin or any albumin containing colloids materials. With these measures, the patient's general condition will be improved and septicemia and infections become a controlled situations. Usually after 8 weeks, the biliary channels status is evaluated by MRCP or ERCP examination. The level of strictures are classified by Bismuth classifications. The Bismuth classifications includes 5 types of injuries. Type 1, when lower CVD is strictures and stump is more than 2 centimeters. Type 2, middle common hepatic duct strictures and stump size is less than 2 centimeters. Type 3, the hilar confluence strictures and right and left hepatic duct intact. Type 4, confluence strictures and right and left hepatic duct are separated. And type 5, involvement of the hepatic intrahepatic duct, which is called type 5 injuries. The treatments of the definitive diagnosis depends on the site of strictures is formed. In case of type 1 injuries, we will do the surgery Ru and Y polydocojejunostomy or hepatoduodenojejunostomy in case of type 1 injuries. In case of type 2 strictures, Ru and Y hepaticoduodenojejunostomy is performed. In case of type 3 strictures, dissection of the hepatic hilar plate and do Ru and Y hepaticojejunostomy. In case of type 4 and 5, the resection of chordate lobe to access into the right and left hepatic duct, and then each duct is anastomosed separately with Ru and Y jejunoum. This is actually a difficult operations. A specialized center is required to do these operations. Treatment of the bile duct injury recognized at operations, it depends on for high complete transections. In these situations, Ru and Y hepaticojejunostomy is done. For lower complete transections, end to end primary interrupted suture over a T-tube, then long limb of T-tube is brought out through a separate abdominal wound and drainage of the bile, and then we manage the T-tube post-operatively and remove the T-tube usually 10 to 14 post-operative days. We do the peroperative T-tube cholangiography or not. For partial lateral injury, insertion of a T-tube and direct suturing over it, Ru and Y serosal pass is sometimes given. Now, I conclude the today topics is post-operative bile leakage or biliary injuries. We conclude every attempt should be made to prevent these disastering complications from relatively a simple procedure which may ruin the patient in all aspects. As the management of complication is a complicated procedure, it should be done in a specialized center by an experienced person. Now, I thanks my students to hear my topics, and I advise you will read your books in bile duct injuries, and in your day-to-day practice you take your patients in good situational conditions. Thank you.